So I want to thank everyone for the hospitality. I apologize for not being able to make it in person, but we've managed with modern technology to do it. So with no further ado, let's just get started with this session that it comes from the one I take all over the world called the Demystifying FOT. So in this case, we're going to give a brief overview of the forced oscillation technique, taking advantage of the moment, which is exactly the perfect time for everyone now to get into forced oscillation technique, or in literature called respiratory oscillometry. So let's get started with the session. The program, it's rather simple. It's basically in 3 sections: the basis and the evolution of oscillometry, the clinical applications, which is ultimately what you are going to be interested for your daily clinical practice, and of course, last but not least, integrating the oscillometry test into your clinical routine. The section number 4, I'm just showing the title to just tease everyone, because there is a lot more coming now on oscillations, such as the handheld device that can be taken around. So think about going to the patient's home or to other labs, and other tests that will be coming out. But today we will focus on the main test, which is oscillometry. I believe that Kevin may have just mentioned briefly who I am and where I come from, but I used to live in Southern California and work for Sensor Medics, Jaeger, and I trained in respiratory therapy and pulmonary function technologies, and I lecture all over the world for the last 8 years on oscillations. And I am a passionate of respiratory mechanics. So that's really big, along with music, as you can all see. So it's those 2 passions in my life, and my family, of course. So I'm going to start from the end and just tell you where we are now, at what point we are now with oscillometry. Oscillometry can now be made daily clinical routine. He's got international guidelines, he's got rules, he's got thresholds for significant response to bronchodilator, he's got a procedure that you can follow as quality control. He's got all the different advantages that come with oscillometry. And in the US, where I used to live, it is reimbursed. One little trick, one little hurdle is that for the moment, and we are working possibly to have that change in the future, you cannot reimburse on the same day forced spirometry and respiratory oscillometry. So we have to find just ways to do it. But in any case, the good news is that the oscillometry test, if you ever wanted to add it, and therefore add the advantages of oscillometry, it's less than 5 minutes. No matter, so remember the rule of the 5 minutes, no matter how sick the patient is, how old the patient is, how young the child is, the oscillometry routine complete will take less than 5 minutes. So let me describe in a few words what is oscillometry. Oscillometry is a fast measurement from children of 3 years of age, approved, FDA approved, to adults, that allows precise detection and localization of the obstruction. So you will know whether there is a central or a peripheral obstruction or a severely heterogeneous obstruction. We also can feature now with oscillometry an extra parameter, which is going to be extremely interesting for all of you for your COPD testing, even over time, and for your pulmonary rehabilitation sessions before and after. And it's called the tidal expiratory flow limitation, which I'm going to describe. Again, very important that we now have internationally recognized technical standards that from a very major group of the ERS, with many participants from the ATS. Now, why is it the right moment now? Because it is not a new test. It's an established, validated, thousands of papers describing forced oscillation techniques since the 1950s. So it's not an experimental device. It's just that it was restricted until today only for research or only for patient that could not possibly perform a spirometry. Well, this has changed because over the last years, thanks to the development of technology and newer devices, the number of publications coming out every day on forced oscillatory technique has raised exponentially. So much that now there is about 2,000 papers, and now that we are releasing internationally the big breakthrough, which is oscillometry portable, so it will be an add-on to the stationary device. Things are going absolutely fast. So again, with no further ado, what is oscillometry? It's a small oscillatory pressure that is applied to the opening of the airways during normal breathing. And it pushes a little gentle pressure in and out from a very large loudspeaker that goes down to the airways and comes back. And we measure what comes back and localize the obstruction. The two parameters that oscillometry measures are resistance and reactance. Again, this is a simple presentation, so I avoid the terms like impedance and all the research terms, but we're going to talk about resistance and reactance. So during oscillometry, this is what happens when the patient breathes, or what you will be able to do with Alvin Zarazua at the end of the session, who has a device there. You will hear a gentle pressure overlaid to your normal tidal breathing. And that's all that happens. And you explain to the patient that the test is very simple, and he probably will believe you, even if the previous time that came, you told him the same thing, and he found himself or herself in a body box with you shouting, blah, 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 blah. This is really simple. The frequencies that this loudspeaker generates travel in the lung, and the low frequency, so the loudspeaker vibrates at different frequencies. It's called multi-frequency. But what's important is that the lowest frequency is the one that travels the farthest away, like seeing a storm on the horizon and hearing the rumble before you actually see the flashing, because those are the low frequencies. And the frequencies are overlaid to normal tidal breathing faster. So this is, if you can see the loudspeaker, this is what happens inside a forced oscillation technique device. There is a large loudspeaker that vibrates, and the patient is just sitting in front of the device. The reason why this was done originally was developed was because spirometry is difficult. Spirometry is a difficult test, is a difficult measurement. So inevitably, but it is a gold standard, and also needs a deep inhalation before blowing forcefully. And the deep inhalation causes in COPD, but even more in asthmatics, an unpredictable effect on the respiratory muscles that can be bronchoconstrictor or bronchodilator. So the solution, the dream of the respiratory allergist, is to have a test that doesn't have the bias of the deep inspiration, and that is now oscillometry, normal tidal breathing. So no forced maneuver and very fast. So the two parameters, resistance. You may remember resistance from the body box, which is less and less used to perform resistance, where the patient has to pant and be closed and be locked into a glass body box. Well, here you're talking about a patient sitting out normally with you standing behind, and resistance is measured in normal tidal breathing and can change during bronchoconstriction if there is mucus or mucus plugging, hence the usefulness in pulmonary rehabilitation before and after eliminating the mucus, inflammation of the airways, and other causes of narrowing of the airways. So resistance accounts for obstruction of larger airways. We have been raised to work with force spirometry. So to give you an idea of what resistance measured with oscillometry is, think of FEV1. Think of measuring the central airway obstruction, but without the deep inhalation. And you measure it before and after a bronchodilator with predicted normal. So you can see very simply before and after using the same protocol as you would use with Ventolin or with any bronchodilator. You can see if and how the treatment has improved at normal tidal breathing. Because resistance is actually measured at 3 frequencies, there is a parameter that is called the heterogeneous index, which actually shows you the resistance and the reactance at the 3 frequencies measured. If it changes, then that means that there is a severe obstruction that you can actually look at by looking at the difference between the resistance at low and the resistance at high frequency. The single frequency, as I was saying, is the most important, period. So the reactance, on the other hand, here is pretty neat to be able to explain that reactance is how well air reaches and ventilates the very small peripheral airways. So it goes below predicted values when there is a peripheral obstruction, when there is a tidal expiratory flow limitation, when there is trapping of the alveolar units. So again, to speak spirometry language, if resistance, you have to think of FEV1, but in different conditions, and resting, not forced. Reactance is actually FEF, forced expiratory flow, at 50 and 70 to 75%. So think of your performing spirometries with your patients, blow, 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 keep blowing, keep blowing, keep blowing, keep blowing until you reach the plateau. Well, here you're looking at the same thing, emptying of the small airways, but at normal tidal breathing. And in fact, with plenty of references, the normal values of reactance follow the normal values of the small airways of FEF 5075, but again, much simpler and much faster. The third parameter of reactance, which is really interesting to understand, but it is very simple, is that because we look at different frequencies of reactance at the different during the measurement, the reactance before and the reactance after, you see, has changed, has lifted, the treatment is working. The area under the curve, and in literature, it's actually called AX, or area under the curve. The area under the curve, it reduces. And so there is predicted values for that. So you know an extra parameter to see if specifically the treatment has worked on the small airways. This technology works on small and large airways, but it's the dream come true for looking at the small airways, which in pediatrics and in asthma is one of the wishes of everyone. So change, the only thing you have to change a little bit from spirometry that we've done for many years is to change the way to look at it. So resistance and reactance. Resistance at the end of the test will be pre and post bronchodilator, and you will see, the post, how it changed. And the same thing is for reactance that changes. But funny enough, high resistance is no good. High reactance is good. Hence, the graphs being upside down. That's the most difficult item to digest. And it is well documented that over time, resistance and reactance are great to indicate changes in the level of obstructions in large and smaller airways when disease progresses. So when the patient comes back for control, you'll be able to actually compare with trending how his small and larger airways are doing. So resistance becomes more positive and reactance becomes more negative as disease worsens. So an exquisite concept of physiology that I can simplify now is that this is how the lung works. The lung, a normal tidal breathing. The diaphragm starts the respiration and pulls, and it generates inside the lung, let's speak in English, negative pressure or a drop of alveolar pressure. Then you let go, in and out, and this happens thousands of times during the year. So there is an alternance of inspiratory, of negative and positive pressure throughout the day, in and out, in and out. So because of new technology, oscillometry can now measure during inspiration that the waves during inspiration, the small airways are all open, because you have to imagine thousands of little tiny balloons that are the small airways, that when you apply negative pressure, they all pop open. So in that case, during inspiration, the waves reach all the peripheral airways. Now, the interesting thing that is in disease state, during expiration, the small airways, because of the positive pressure, are pushed together. So the waves, the stimuli doesn't reach. So we actually can now really measure in and out. And this is why you get three parameters: inspiratory, expiratory, and total. The main one that you want to look is the total, which is the sum. But it's interesting because the expiratory parameters are what can be used to see at the end of the test that there is a disease. And the inspiratory change pre and post, look at how evident it is. It's actually the best to measure changes due to treatment, any treatment. So that's how it makes it really simple to use. So to summarize, the most important parameters are the inspiratory and expiratory resistance and reactance at the lowest possible frequency, and the flow limitation. So the only slide I really show about literature is that it's been proven already since many years, I think is 2009, that when you look at a change of total resistance, which includes both inspiratory and expiratory before and after bronchodilator, you often see no change with a expiratory flow limiter, so with a COPD patient. But when you look at before and after the inspiratory, that's where the magic happens, and that's where you see changes. So it's been documented depending from the disease. Check this out. In asthma, both of them are sensitive. In COPD, the expiratory, you actually see it more, and in interstitial lung disease, you see the inspiratory. So it's very, very well documented, and it's called within breath oscillometry, because we're actually looking at it throughout the whole cycle: inspiratory, expiratory, and total. So why are we so now safe to use it in clinical practice? Because like the ATS and the ERS guidelines for spirometry, DLCO, and lung volumes, oscillometry has international guidelines. And the most devices that are out there should meet them all. Ours does. And basically, they give you the rules to make the 2 or 3 measurements repeatable. Like in spirometry, forced spirometry, they have to have a repeatability of 5% each one. Here, the repeatability is 10% for adults, adults, 15% for adults, and 10% for pediatrics. And obviously, the devices tell you that you are okay to go. Most important, there is published standards for reversibility values. So if with for spirometry, you use 15% of FEV1, here you can use authorized and approved 40% change in resistance and or 50% change in reactance, because a patient that comes in with both central and peripheral airways issues, you can broncho-reverse it in resistance and or reactance. And here you will see where it's working. It's working on the small airways or on the large airways. And again, I underline it again, all at normal tidal breathing. This is the very important thing of oscillometry. So again, now let me see. Okay, so how does a session happen? We know about spirometry. We worked with spirometry all our lives. How does it work with oscillometry? You do a first measurement, so 10 normal accepted breaths. The patient rests for a few seconds. Then you do a second one, and then rest for a few seconds, and then you do the whole thing, the third one. So remember the rule of the 5 minutes. All happens in less than 5 minutes. No matter how the patient is sick, no matter how young. When with a sick patient or a young child, you can't, very few people can do spirometry on preschoolers. So say 5 years old, 6 years old, well, you got a lot of explaining to do. And the same is with an adult. So typically can take between 20 to 40 minutes for the most severely sick, because you have to explain and you have to repeat the test. And then you have to ask the patient, John, to rest. Okay, let's do it again. Blow, blow, blow. Oh no, you didn't make it. So, and so here is always less than 5 minutes with an average duration for a spirometry of 30 minutes. So advantage number one in your clinical practice is speed. You're going to reduce your waiting list. And even with oscillometry, although it doesn't require a force maneuver, it's required some quality control, because the patient, patients, they can cough, they can swallow, they can close the glottis, they can leak from the mouthpiece. So there is a special quality control that allows you to overcome all that, and only the breaths, the good breaths, are accepted and considered. And you can even, after the measurement, you can even go and explore what you just did and check why the algorithm has discarded certain breaths, and you can admit other breaths, and you will see the result immediately on the measured parameters, which will be ventilation and tidal breathing, resistance and reactance, and that great tidal expiratory flow limitation. So the quality control is guaranteed throughout the test. So having said that, let's now go on how do we use it? Detection of central and peripheral airways obstruction. So again, here is the screen that you just have to get used to it, but users around the world take about 10 minutes to understand that you're going to look at resistance and reactance, and you're going to look at the normal range of resistance and the normal range of reactance. And if after the treatment, if before the treatment the patient is out, in this case, look at the reactance, big peripheral obstruction, and resistance, borderline central obstruction, and look at the difference before and after on the three components, the treatment worked. And look how well it worked for reactance. It's much, much, much lower. So the oscillometry has normative ranges from 3 years of age to 90 years of age. So it's no problem. You always will be guided and be told when there is a parameter that is outside the range. And let me now talk to you about what we considered the game changer of oscillometry, just published on or basically the ATS, but is the most important journal in respiratory medicine, the American Journal of Respiratory and Critical Care Medicine, in February. And we call this a game changer because it's called Diagnostic Potential of Oscillometry. Why is it game changer? Because you read scientific literature and you can publish a paper with 10 patients, with 50 patients, with 100 patients, and already is a success. This is the largest study, longitudinal observational and cohort, on 7,500 subjects of general population that they screened to find a number of COPDs, a number of asthmatics, like in real life, and found that, and it is done with oscillometry and spirometry together. So think of 7,500 patients that have done oscillometry and spirometry. That's a lot of patients. 20% of the adult population have an abnormal oscillometry, when 13% have abnormal spirometry. So you detect more patients that have symptoms. So that's very interesting, because a patient with symptoms and a normal spirometry, which can be an asthmatic. I mean, many asthmatics, which is a nasty disease, will come in the good day where they will have a rather normal spirometry, but they are asthmatics, and you will catch them with oscillometry. And funny enough, we found out on 7,500 subjects that the most sensitive indicator of symptoms and disease is actually reactance, the small airways. It's where you actually will see more of that. All of this, it will be available at the end of the seminar with the educational material package. If you give your email address to Alvin, because we will send you the educational package for you to kind of get into oscillometry. This is a very important part. It's 4 slides, and it will tell you that oscillometry confirmed it's a tool for detecting and evaluating abnormalities that are not seen by spirometry, even in subjects with symptoms. So, and as well as a higher sensitivity than spirometry to small airways in conditions such as COPD and asthma, which may not be fully seen by spirometry. So it is an interesting graph to see how many patients have abnormal oscillometry, how many patients have abnormal spirometry, and how many patients have both. So it is really the sign that you can start using it now routinely, because you will see more than spirometry. And the same issue had an editorial that is very important, that actually underlines how the study influences the evidence supporting the clinical role, because it validated the clinical relevant diagnostic potential of oscillometry, even when spirometry is normal, and shows you insights of the lung that cannot be gained by routine spirometry. And the most important parameter is actually reactance at 5 Hertz. So, number 2, bronchial reversibility testing. So we all know why we perform bronchodilator testing. I mean, I don't want to offend anybody's intelligence, but we understand how we do pre and post bronchodilator, and we understand the protocol, how we do it. Well, because now oscillometry is really at the same level as spirometry, before you ask, the measurement, the routine, it's the same. Treat oscillometry as you would treat spirometry, period. You just use it the same way, waiting the same way between administration of a bronchodilator and the post-bronchodilator assessment, the same thing, and you look if the test is positive with the percentage of change. So oscillometry was proven to be more sensitive in symptomatic non-smokers, as well as in symptomatic and asymptomatics. So this has a present and a future for screening of smokers. A smoker will not quit smoking until he sees and you tell him that there is an issue with spirometry. But when there is an issue with spirometry, it's often too late. Here it's been demonstrated that you can see prematurely, for example, in screening programs, when there is a problem, and start recommending to quit smoking. The technical standards have just gotten an update a few months ago that now give you different thresholds for significant response for adults and children that are considered into the calculation and into the devices. So 30% for adults and 40% in pediatrics for resistance, more increase of 40% and 50% of reactance in adult and pediatrics. I don't know how many of you want to do that. Normally I ask, but since we cannot communicate, it's only 2 minutes. I want to tell you bronchial challenge, which is also an important test in asthma. The important point of doing bronchial challenge instead than spirometry using oscillometry is that the tidal breathing avoids the deep inhalation, which is called a confounding factor because of the deep inhalation, and then you give methacholine or histamine, and then another deep inhalation, and then methacholine. Well, here you don't need that. And there is thresholds published by the ATS and the ERS about the threshold for positive response to bronchial challenge, like I'm sure you're aware, the PD20, so the 20% drop of FEV1 during the protocol. And before you ask, I confirm what I said earlier. The protocol is the same. You actually measure a baseline, In this case, I used inspiratory resistance at 5 hertz for the reasons that I outlined. It's the most sensitive and sees the whole lung. And then I give my metacholine. I perform another 10 breaths, metacholine, another 10 breaths until you hit the thresholds that you have selected. And then you do, like with spirometry, bronchial reversibility. That's it. In terms of time, who does it knows it is a hassle. 5 times less than doing a bronchial challenge with spirometry. So that is something that many people around the world have restarted doing metacholine challenge because they were fed up with the time it takes and with the discomfort to the patient. So our good old friend Alan Coates from Canada has actually just published a review that says they propose an ingenious solution to avoid the confounding factor using forced oscillation rather than spirometry, avoiding the deep inhalation. So that is actually becoming even more interesting. And of course, there is validations that you can use forced oscillation instead than spirometry and to diagnose assessment of asthma. And because it's more sensitive than spirometry, the funny thing, but not so funny, is that you will actually reach positivity earlier than spirometry. So another paper that shows that FEV1 actually happens a little later than the drop into of the resistance at 5 hertz done with metacholine. Same thing is with mannitol. So you can really use any bronchoconstrictor. You know, again, I think that by now you understand it is a normal tidal breathing that measures central and peripheral obstruction. So last but not least, the flow limitation. Again, remember the exquisite concept of physiology that you inhale and inhale, negative pressure and positive pressure? Well, this is my favorite graph that explains something very important in COPD. Unfortunately, it gives away the fact that I'm not 38 as I pretend to be, but this is my birth year. So it was published in my birth year, and it basically shows you that when a patient has a severe obstruction, they inhale, and exhale, and the system doesn't give them enough time to exhale before catching the next breath. So what happens in the COPD patients, as you are aware, is called lung hyperinflation. So the patient starts autonomy, but just by itself, defending himself from the flow limitation that they experience, and he starts increasing the lung volume. So he breathes at higher lung volume. So the purpose of your treatment, the physician will prescribe drugs or non-invasive ventilation that actually lowers the lung volumes and makes the patient breathe more restfully. Of course, in these patients, as you well know, the inspiratory capacity, if you perform a slow vital capacity, the inspiratory capacity is reduced because they breathe at higher lung volumes. And therefore, the residual volume measured by body box is increased. So having said that, when you ask a patient to perform a flow volume loop, a spirometry, if they can, it will be for them like blowing through a straw. So the maximum flow will likely touch their normal tidal breathing. And this is the typical spirometry that you see, because I'm sure that you're good, even with patients very sick, when they blow, 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 and that's what they can do. They can just blow and touch the normal tidal breathing. These patients cannot climb stairs. They cannot walk faster. They cannot ventilate any faster than that. And they often come in with a stroller. So these are because they basically are flow limited at rest. And it's been very well published, also using oscillometry, the method that the expiratory flow limitation leads to dynamic hyperinflation and rarely can be reversed. So the graph that appears at the end, along with the two important ones that I showed you, it's the tidal expiratory flow limitation. It's what is detected as the difference between reactants, the small airways, inspiratory and expiratory. If this difference is very high, it's been published that there is a threshold, and the patient, you will see it in the red zone. So if you manage with your patient, with your treatment, to give him a bronchodilator or physiotherapy or anything that can lower the flow limitation percentage, chapeau. Chapeau. So it is a percentage. 100% the patient is completely flow limited. 75% you have improved his functional capacity to an expiratory flow limitation of 25%. Fantastic. So you have a very important index that has been validated to actually show, even in patients, not only patients that have less than 30% FEV1. Look how many of these patients have a flow limitation, which is past the line. Well, you could tell me, Robbie, a patient with 30% FEV1 predicted, we don't need the parameter because we know that most of them are. But the surprising thing in these large studies is that patients with 30, 40, 60% of FEV1, there is a significant number that has expiratory flow limitation. And it correlates with hospitalization days, as well as it correlates with mortality. So it's a prognostic value for mortality. In other words, between us, the patient with high flow limitation lives less than a patient with no flow limitation. Very simple. All of this is in the literature, of course. And whoever you wants to do research or wants to do any statistics, all the data can be saved, and you can, after 6 months, pull out an Excel spreadsheet with all the selecting all the patients that are older than 60, with resistance very high or reactance very low, with a certain BMI. So the sky is a limit even for research. So having said that, we are right on time. Fantastic. How do we integrate in clinical routine? Well, now that you understand the few things, simple things, we basically measure the patient with the first measurement. Is the ventilation low, which means that the patient is breathing quiet, which is not a given, because the patient doesn't know that you are actually doing a very simple test. So the thing you look at the ventilation, and you will see ventilation is the product of tidal breathing for respiratory rate. So a low ventilation means the patient is relaxed, and you will follow it in real time. Is the coefficient of variation of the testing, the second and the third, within the limits? The test is repeatable. Great. Now, is there resistance or the reactance or both abnormals, central or peripheral airways, or both? Is the COPD patient experience dyspnea, shortness of breath, and has EFL? Okay, well, then also you can look at that. And then you integrate spirometry, oscillometry, exactly the same way as you will integrate spirometry. So you don't use spirometry alone for a diagnosis, but you also use patient clinical history, symptoms, and results from other diagnostic tests, such as blood gas, DLCO, lung volumes. Now think of replacing your spirometry with oscillometry, because it's got the same power and more. So what subject? Now, what subject is easy? Subjects unable to perform spirometry. Those goes without saying. Of course, those are the ones that they can't perform. But also important, documented, symptomatic subjects with normal spirometry. Also, subjects for which spirometry is contraindicated. And I'm sure that you know the ATS and the AARC guidelines of the many conditions where spirometry is actually contraindicated. Then allergic asthma. So recommended recently, this is a very recent article, to use forced oscillation technique or impulse oscillometry, which is the older method, as a standardized manner and as a potential outcome measure rather than FEV1. So again, allergics, how many patients? How many? Of course, this is less for you, more for a general practice. It's that 40% of the spirometries do not meet ATS acceptability. Not you, of course, because I trust, I worked and I studied there, and I trust that we do things right. So where? Let's name it now. Pulmonary departments, pediatric departments, including off-site testing. You can bring the device to the school and do screening. respiratory and neuro rehab, before and after thoracic surgery, before and after physiotherapy. Remember, tidal breathing, harmless, normal testing for 10 breaths. Internal medicine and elderly, respiratory allergy, occupational medicine. And here is where the patient comes in referred by his boss. Maybe they work in a hairdresser or in a body shop and says, I can't breathe well because I breathe all day, funny stuff. Well, a lot of these patients don't want to do a spirometry. And so you say, no problem, sir. Sit here and just perform a normal tidal breathing, and you will see if there is an impairment without cooperation. Of course, great for screening, and we got many who go to the factory and do, in car factories, 60, 70 subjects per day, per morning screening, which you can't do with spirometry. Cystic fibrosis is obvious to look at the effects of the physiotherapy, and of course, primary care screening. So, summary, and we're almost done. Oscillometry is faster. It requires 3 measurements of 10 breaths, less than 5 minutes. It's more comprehensive. You look at small airways, especially the spirometry may miss. Less effort required for the patient, so it makes it more suitable for all patients. It's more sensitive. Remember the result, the game changer? Oscillometry is more sensitive to small changes, and it's better for detecting early sign of respiratory disease. And last but not least, accepted and standardized and reimbursed. So it's now published technical standards with recommendations. All of this will give you a better respiratory diagnosis. So to end the session, I put together, and I'm very proud because I take care of the science, we put together something that we will send you later, this set of slides that Alvin will get emails from you. So we send out every month the publication list with updates because it's so many papers indexed by subject. So I will send you one to see that you can actually look at what is published with these devices in COPD. You click here and it gives you the papers in asthma and so on. I have written a great paper, not because I wrote it, I written a great review a couple of years ago that was published in one of your magazines, which is called Respiratory Therapy for the Therapist. And it's called a review in 6 pages of everything that I spoke about it today. So the technique, the clinical research uses in 6 pages. I ask you, please, and I will send you this with the package, 15 minutes to read it, because it's the best cliff notes or cheat sheet that you can get, because it's plenty of references that I got the text from, and it's really a good summary of the advantages and of the technique, including using it with exhaled nitric oxide, which is a potent biomarker of eosinophilic inflammation that, together with a biomarker of obstruction, allows you to look at asthmatic patients prematurely. We wrote the ultimate cheat sheet of the 5 steps guide to perform the measurement. So with good quality control. So check the posture of the patient, that the patient has a relaxed neck, measure the patient, ensuring that the ventilation is low, perform a second measurement, and now it becomes a session with coefficient of variation, evaluate the result, give a treatment, and evaluate the response to treatment. That's all there is to do. And when I published that, physicians said, thank you, Roby. Now we know how to do it well. But how do we evaluate it? And here is an interesting summary that is very important to remember. Using oscillometry should be similar to how you would use spirometry. So as I said earlier, considering patient clinical history, symptoms, and results from other diagnostic tests, because oscillometry can detect presence of central and or peripheral obstruction, patient responding or not to therapy. So centers are getting used to this and are not doing spirometry, especially before and after bronchodilator, because spirometry may miss the response and it takes so much time, when now it is approved and widely used to look at patient responding or not to therapy and detect abnormalities during normal tidal breathing. For certain cases, if the physician has doubts, you can actually combine FOT with traditional spirometry. But what is important is that you get the message that this can be done easily. I enclosed one video here of the VA in New Jersey, because we are very big in the VA systems in the States, and many are using oscillometry. And they actually published on a journal, including a video, a 6 minutes. I suggest you, when you get the material tomorrow, you click on this and you actually see this very interesting, clear video where it shows you how to prepare the patient, verify before the test, like we do with the syringe. There is a verification tube of known resistance and known reactants, because that will actually cover you for liabilities and responsibilities, like the 3-liter syringe for spirometry. You will actually be covered because the system works. You can diagnose, you can prescribe therapy with no problem. Perform a session, determining acceptable measurement, reporting, and interpreting. We have a cheat poster to look to help you, if need be, to look at the two important graphs and the flow limitation. And I recorded a couple of years ago, by popular demand, the recording of the long version of my presentation, which is you click basically on the schedule of the program, and it takes you to the small section where I come out dressed like a CNN journalist with the background, and you can listen only to the section of interest. For example, you forget what Roby said about the parameters measured, you click on section number 2, it takes you there, and in 3 minutes, with a big advantage that you can put me on pause, which is not something easy to do live. So that's pretty interesting, and you will get that as well. They asked me a year ago to record a condensed version, and that is an open access that by clicking on the link that we provide, you'll be able to go and look at it and again pause me. This is the same schedule, but quick, of 30 minutes. So what we're talking about it now, bronchial hyperresponsiveness, measuring tidal expiratory flow limitation, and so on. The ERS published to prove you how powerful this is becoming. The ERS is published at the end of October with Dr. Charlie Irving from Vermont as a chairman, a course more for physicians, very detailed, again, to look at the clinical applications and so on. So oscillometry is there to stay. Also, and I will show you a little piece now because we have a couple of minutes. Yes, we do. I actually recorded from that video, that 30 minutes video, I recorded only the performing the test. And I want to show you that, which basically answers the question, can we see how the test is performed? And this is actually something that you can access separately. And the last but not least, we just published it, and it goes to our users every month, a new clinical tip document that by disease tells you how to use it. So in pulmonary departments, you will be able to answer the question, is there an obstruction or an alteration in the airways, and where is it? Is the obstruction reversible? Does the patient has expiratory flow limitation? In pediatrics, is there an obstruction? Is the obstruction reversible? In asthma, same thing. Identify the presence better than spirometry. In rehabilitation, show me abnormalities before and after therapy, the physiotherapy. In internal medicine, in cystic fibrosis, in occupational medicine. So to end the session, here is the icing on the cake that you will be able to see. And we are perfectly on time, Kevin. So here is the how to hook up the patient, calibrate the device. The patient starts breathing, and you will see now Alvin has a device there, and I recommend you to do two tests, just to do both and measure the repeatability. You'll be able to breathe, holding your cheeks to prevent fluttering, and if there is a count, as you see, of accepted breaths. So you breathe and you see the flow, the resistance and the reactance, the numbers on the right-hand side. So you'll be able to see if the patient is already very obstructed in real time, and you see the count. And if the patient coughs, and I will suggest you to do it, cough, you just close the glottis, do something odd, and the count will stop. So here is the cough, and the count has stopped at number 7, and it will resume only when you will see acceptable results until breath number 10, when the test is over. This is how you perform a forced oscillation test. Now, if you are going to look at the rest of the video, you will see that at the end of the test, you will see the results, resistance and reactance. In this case, this patient has normal resistance and normal reactance and no expiratory flow limitation, of course. So, which shows here. So that's pretty good. The number of tests that you've done, you've performed, and that's about it. So I wanted to thank you for the attendance here and for the time. And I'm going to now unmute all, if I can, and I'm basically finished. So go ahead.